Okay, now we have Dr. Amena Fine, who's up next. Amena is an assistant professor of neurology and developmental medicine at Kennedy Krieger and Johns Hopkins. So Amena's research has been focused on kind of advanced MRI use, mapping spinal cord and brain, and it's correlating it with gait and sway in AMN. Thanks, Amena.
Thank you, Keith. And actually, we have our special guest as well here, Eda Kabak. And I'll sort of explain. So, essentially in rare disease, especially for this adrenoleukodystrophy clinical research, it's really essential that we collaborate. And so, as you have already heard from this morning's talks, a lot of our centers are working together. So, in particular, the last few years, our center at Kennedy Krieger and Amsterdam have been working together on this longitudinal cohort of men and women with ALD, trying to sort of see what's happening with spinal cord symptom monitoring with wearable technology and other means, and hoping that we can establish some clinically meaningful trial endpoints. So that's what we're both going to talk about today. I think we already have had some nice introductions, but just to make sure everybody's on the same page in terms of the background that's relevant for this talk. So ALD, of course, is an X-linked condition due to pathogenic variants in ABCD1 gene. This, of course, plays a role in breakdown and regulation of very long-chain fatty acids in these key tissues. So we see that VLCFAs increase in the blood and myelin and adrenal tissue. So the phenotypes, we'll talk about phenotypes of ALD, but as we know, there is, evolution where certainly, especially males, might experience all three of these phenotypes throughout the lifetime, and even females, rarely all of them. But essentially, cerebral ALD we primarily see in males. Boys that are between the ages of 4 to 10 are very vulnerable. Adult males as they get older. So this is the rapidly progressive inflammatory brain disease with demyelination. There's the adrenal insufficiency, which affects primarily males, but also some women. And then I'm going to really focus on the myeloneuropathy with or without adrenal insufficiency. And so in this case, you have this, this distal axonopathy. So there's, nerve cell damage to the axons. We know myelin loss is involved, most likely secondary. And so all adult males, and actually really the vast majority of females are involved. So sort of honing in a little bit more on AMN. It's basically the closer we look and the better questions we ask, the more we involve women in research, the estimates keep rising, where now it's really 80 to upwards of 90% of females that we know are affected. So you won't hear the term carrier anywhere in this talk, and I think it's sort of really going away for the whole, yeah. And I think most of my colleagues are doing the same now. So we know that males have a symptom onset, the spinal cord symptom onset, mostly between 20s and 40s. Most women actually develop at least some symptoms in the 40s. And so there's really progressive worsening of the spinal cord changes and peripheral neuropathy also. It might be a little hard to see. Oh, sorry. There we go. Might be, I forgot I have to use the pointer separately. So in this diagram, you can see the spinal cord section in the blue. That's representative of the dorsal columns. So those have this really important role with receiving sensory information with the body, to help basically process vibration, a fine touch, and sort of understanding of where the body is positioned in space. And then the corticospinal tracts are involved as well, and so that's motor control, sort of really fine-tuning motor control for the limbs. And so as a result of those changes, we have progressive gait and balance impairment, weakness, spasticity, and because of this extensive spinal cord involvement, also bowel and bladder dysfunction, and people also report fatigue, pain, and a lot of psychosocial impacts related to this. So, of course, much progress being made with, in terms of stem cell transplantation, gene therapy, these available options to help halt the progression of cerebral disease, but there are no treatments right now for for AMN. So it's really critical to understand what are the current unmet needs, what's the disease burden. As a really important step in this direction, several years ago, ALD Connect hosted an externally led patient-focused drug development meeting with the FDA. So I'll talk more about that in the next couple slides, but this sort of really great chance for the FDA to hear in the patient's voice directly what they want for treatment needs and outcomes. So this report was published from that in 2023, and happy to announce that we have a publication just accepted in the Orphanet Journal that's coming out in the next couple of months, sort of going over these findings again and to raising the visibility of that. And then ALD Connect continues this work, so even just in the spring, I think about 100 people participated in surveys about what's important in terms of quality of life, what do they think about risks and benefits of being involved in trials and the like. That's all on the website. So as we're getting this information, it's still critical to capture outcomes that are sensitive to change and meaningful for patients. Okay. So I'm going to revisit some of the results from the patient and caregiver polls from that PFDD. And really the goal is to try to match the stated needs of patients with what we can measure about sensorimotor function, whether that be in the lab, with clinical scales, or with wearable technology, which is our focus today. So I'll talk about this collaborative project we're doing. We've already, I'm going to show some figures that we've published already, actually, cross-sectionally about relationship of sway and gait with ALD severity, relationship of sway and gait, and as well with meaningful clinical outcomes. By that I mean, how does it differentiate people who use a walking device versus not? How does it impact what people report about falls, and also their quality of life? And then Eda is going to join at the end to talk about the really exciting data on how these measures change actually over 1 to 2 years of analysis. So for this PFDD in 2022, the people who participated were, I think it was about 60% of people were patients, 30% caregivers, and then some women who were primarily in both of those groups. It was about a 50-50 split of males and females, and mostly the ages of 30 to 70. And so the first question asks, which of the following ALD-related health concerns have you or your loved one ever experienced? So balance issues and altered gait were at the top of that list. And then a similar question, select the top 3 most troublesome symptoms related to ALD that you or your loved one have ever had. And again, balance and altered gait were at the top of that list along with incontinence. So it's something we really have to focus on. The third question was, what specific activities of daily life are you or your loved one not able to do due to ALD? And walking is far ahead of the pack with those responses. And then finally, what worries you about you or your loved one's condition in the future? And so at the top of that, really it's all related to disease progression. They worried my symptoms will become worse, that I'll lose my ability to walk, and of course, developing cerebral disease was high. So I've basically already explained how why it's important to monitor spinal cord disease progression from a patient perspective. Of course, this is also critical for our sponsors, our industry trials, to know what can we measure, what might be responsive to treatments, and we can't in a disease that sometimes is slowly progressive, or has variable progression. We don't have 5 years or 7 years to do these studies. We sort of need to figure out things that might be responsive to treatments over a year or two. And so clinical scales have been widely used to try to understand disability status and severity. One limitation is that even those are really great, at one point in time, when we try to re-administer those clinical scales, we found that it takes either several hundred patients to be involved or quite a number of years to be able to see those changes manifest for the group. So we need more sensitive measures that we can look at. So our approach for this has been to use wearable sensors to kind of like basically give people the most opportunities to participate. So these can be used in person in a clinic, in person in the conference, as we're actually doing on the other side of the lobby today, or in people's homes for remote collection. It's really user-friendly. I mean, I hope most people would agree who participate at home that it's pretty easy to set up, and I know that it's pretty easy to train new staff to use them. And it really gives you much more flexibility with how often you can get these data points about walking and balance. And then it's not like a set it and forget it where we send them home and you do all the work. We still sort of basically set up a tele-research visit where we're directly supervising over about 45 minutes or an hour to get this information. So these basically, there's a picture. They look like a Fitbit. It's this small device, and we just use 3 of them, 1 on the waist and 2 on the feet for these tests. And there's like a long history, actually starting in Parkinson's disease, but also in multiple sclerosis, pediatric and adult onset ataxic disorders. So they've been used for about 20 years. It's novel, but thankfully not too novel. So, and then for our remote testing at home, we send the wearables kit, a remote-controlled camera, a laptop, and a device manual, and that's all we need. So who participated in this study? So basically, there are about 120 patients between Amsterdam and Kennedy Krieger Institute. The OPALs collect a lot of information, but we're going to just sort of focus on a selection of those variables today. And then just in terms, I just show the demographic information that it's pretty representative of the patient community, with women who have slightly, or skew a little bit slightly towards older ages. And then we have sort of this group of men that have low EDSS scores that are younger, and then the men that are that have high scores that have dealt with the disease for much longer. Okay, so sway, we just need 1 sensor at the waist to measure this, and we do 4 standard conditions. Standing with the feet apart, eyes open, feet apart, eyes closed, which sort of challenges the dorsal column or proprioceptive input, and then feet together, eyes open, and eyes closed. I've sort of emphasized the first 2 because those are usually pretty easy for people to do, especially over time, and we've got great information from those. And so we can look at basically, front and back direction and side-to-side direction of sway. This girl who's represented here, I'm not sure if these videos are going to work, but you can at least see this is from another leukodystrophy with a myeloneuropathy known as LBSL. But just as an example, you can see her sway plot over 30 seconds in comparison to the healthy matched control on the left. And so a lot of difference, especially with the feet apart, eyes closed condition. Okay. So the first thing we found was that sway is really tightly correlated with the Expanded Disability Status Scale. This is one of our most well-used clinical scales for severity in AMN. So basically, we found these significant relationships both for the males and the females. The RMS sway is the root mean square of the sway. We like that measure because it actually approximates sway amplitude on the force plate, which is a gold standard measure that's used in the motion lab as well. So this was exciting to see, especially the data for the women. The next thing we looked at is, that across several different sway variables, the RMS sway, the total sway area, and then the length of the path over 30 seconds, that it was sort of clear to see that people who needed a device to walk swayed to a much greater extent. This is for both the men and the women, but it was especially striking for the men. And actually, if we looked at a RMS sway degree of 0.2 meters per second squared, there was really only 1 person who used a walking device that had less sway. So pretty significant threshold of change there, of difference. We also looked at walking tests. So the 6-minute walk test is a really challenging, fast as possible paced walk. The 2-minute walk test is self-selected. We like to do both in part because, it can be really fatiguing and impossible for some people to do the 6-minute walk. So the 2-minute is actually attainable. That's also one we can safely do at home. So we're basically doing both of these paradigms at our site. And just so you know, so for reference, a gait cycle is this period from when the foot first touches down or makes contact with the ground, that's usually a heel strike, until the same foot makes makes contact with the ground again. And so the opals get about 20 different variables based on where the foot is positioned during that gait cycle during these walk tests. So we saw essentially that looking on the, I guess it's on my right, your left, for the 6-minute walk test gait speed, that for both men and women, there was a significant relationship of gait speed with the EDSS. Looking at the 2-minute walk test, for our U.S. data, at the time of publication, we didn't have many people do the walk, so that we didn't see a relationship. But for the women, we were able to determine that there is a strong relationship of that self-selected walk speed with the EDSS. And then this is another, it's a pretty unique variable to the opals, so they're on the ankle. So it lets you get angles of where the feet are positioned. And essentially, so the toe-off angle is that angle, as the foot is leaving the floor during stride, that's the angle that's there. And, essentially about 45 degrees is normal, and you can see that for patients with the high EDSS levels, that the toe-off angle significantly decreases. And so this was for both walk paradigms and for both men and the women. And I meant to say that the toe-off angle, so, we think that might relate to, things such as having weakness as you're trying to initiate that stride, and sometimes spasticity at the ankles will decrease the range of motion, decreasing that angle. So there seems to be that there's a physiologic, explanation potentially for that. So next we looked at falling frequency. So this is actually the Amsterdam group that sent out this survey of falling actually every 2 weeks over 9 months to the men in the cohort. And they simply asked, did you fall or not fall in the prior 2 weeks? So you can see about 25 of 39 men reported falls and 14 no falls. So we were actually able to see that that sway in both the feet apart, eyes open, and feet apart, eyes closed conditions did significantly correlate with falling frequency. And then we also saw that the gait speed was correlated with falling frequency. And this is the last slide that I have, but we also wanted to look at quality of life. So the short form 36 is a really well-used quality of life scale. It looks at 8 different domains of function. It's patient-reported. And so we were able to see that for 4 of those 8 domains, there were significant relationships with the level of sway. So in order of strength, the physical functioning, so this is basically if people felt they had limitations in their physical activity in daily life, and general health, so their personal rating of general health, how they felt compared to peers and their expectations for the future. We saw a relationship with energy or fatigue, and also with pain. So at this point, I'm going to have Eda come up, and she's going to talk about what some of these key variables have looked like over 1 to 2 years of measurement.
Thank you, Amena. After we saw the correlation at the cross-sectional level, we had to assess whether these metrics changed statistically significant over time to be able to use them in clinical trials. And one of the metrics I want to start with is the sway path length, and that's actually the trail of the sway in the transverse plane. And when we look at our plots, you see the combined data of both the Amsterdam Center and the Kennedy Krieger Institute with men and women together. With the red ones and the blue ones, the Amsterdam data, and the orange and the gray ones from the Kennedy Krieger Institute. The red ones and the orange ones are the patients with the walking aid, and the others are the patients without. You see a lot of variability in our plots, but what we also see, and what we're very happy to see, is that in the 3 of the 4 paradigms, we see a statistically significant change between 2 years follow-up and baseline. The most difficult paradigm, feet together, eyes closed, may ask, why don't we see there actually a significant change as we would expect? We think mainly that's because there are less patients in that group, because as you can see below, that group contains 48 patients compared to 60 in the more easy paradigms. And also when the paradigm gets too hard, people tend to actually fall off the plot because they won't be able to do it anymore. Then I want to go to the root mean square of sway, which Amena also introduced previously. That's a calculation actually between the sway between the coronal and the sagittal planes. And here we see a statistical significant change in the feet apart, eyes open paradigm. And what we also see is that not only we see a significant change between baseline and 2 years, but also between baseline and 1 year. So that would make it very suitable to assess change in a short period of time. Then I want to go to the sway area. This is actually the area covered of sway of 95% of an ellipse, which covers the area you actually wobble. And this is only the plot of the feet apart open paradigm. And here we also see a significant change over time statistically. And this also actually goes for the sway range. So we have actually one more metric that is correlated or that significantly changes compared to the cross-sectional levels. And that's actually about the sway parameters. Then we come to the Gait metrics, which are actually harder for patients who are more severely affected. So we have less numbers in this group. But what we see here on the left side, you see also the mixed patients with the gray ones, the patients without a walking aid, and the blue ones with a walking aid, and the red line is the mean line of the gait speed, which actually says how fast you move forward. And here we also see a significant change over time between 2 years of follow-up and baseline. When we compare those two groups of the walk aid users and the non-walk aid users, the blue lines being the patients without a walking aid and the orange ones with a walking aid, we see that there is no difference in the slope of progression of these patients. So the y-axis shows the delta of the gait speed. And when we compare that to follow-up over time, we don't see a significant change in those two groups. So they actually progress like similar to each other. And lastly, I want to go to the toe-off angle, which was the angle of the sole of the foot just before the foot leaves the ground when walking. And here also the gray ones are the patients without a walking aid, blue ones with a walking aid, and you see that the toe-off angle decreases also significantly over time. And here, the smaller the toe-off angle, the worse the patient. So that means that you have more difficulty to lift your foot off the ground. So actually, to conclude, we saw for the sway significant correlations with the EDSS in both sexes, for men and women, and also for the quality of life. We did see cross-sectionally that there was a differentiation in sway levels between walk aid users and non-walk aid users. And what we were so very excited about is that we saw statistically significant changes over time, short periods of time, in our AMN cohort. And these are patients, both men and women. And for the RMSWay, even an increase in 1 year. And our next steps would be to correlate this to the clinical parameters like falling over time. And for the Gait, we also saw significant correlations in the EDSS for both sexes for fall and quality of life in men in the 6-minute walk test and for the toe-off angle in both tests. And also significant changes for the toe-off angle over 2 years. So thank you for listening.
Questions?
Do you have enough data to run a power analysis to figure out how big, how long of a study you would need to run in order to see maybe a 50% reduction in progression of changes?
We haven't done that, but we certainly can. Absolutely.
Great.
It's a great idea.
Other questions?
I just got a quick one about when you have walking devices or help with walking. Is that mostly canes and walkers? And is anyone looking at using, technology like skip and those kind of exoskeletons to help with sway and gait?
Yeah, sorry. So in terms of the walk aid, for this study, we had we included people who their EDS score was up to 6.5. So that basically means so people who had a single cane or even people who used bilateral canes or crutches could participate in the walking. But we didn't have anybody in a walker I know that at least on the Kennedy Krieger side. And then that's a great question about exoskeletons. We have, at this point, our main rule has been, whatever equipment you were using at baseline, we obviously, to be able to track over time, we'll need that to be consistent. So, certainly even if people, if they have, some kind of a new brace or device or exoskeleton, even if they've acquired that later on, for the purpose of the testing, we sort of want to keep all of those variables the same. But it's a good question if we get enough of a bigger population of people that are using them that we could look at it separately. Yeah. Mm-hmm.
Very nice. I was wondering if you had a sense for the balance issues related from dorsal column versus any peripheral or neuropathy component, and whether you guys thought about nerve conduction, or just, if not, your impression based on your interviews, or whether it's on a survey question of how much of some of these issues are being complicated by neuropathy, or if it's truly just a dorsal column issue.
We don't make that distinguishment. In Amsterdam, it's mostly, we do the vibration tests, but not specifically EMGs. But it's certainly good to look at those differences in pathology, I think. But we don't have a clear view on that right now.
Yeah, it's definitely, Nadav, it's a great question. It's something that, probably if my career development grant gets funded, it's something that I certainly plan to do. We just, we know that the peripheral neuropathy exists in AMN patients. We know that it's probably not everybody, sort of based on some of the older natural history studies that I remember. It's just not something that we're tracking on a regular basis. But I do think it would be awesome to get at least a subset of our natural history cohort to sort of better understand what's that contribution of the peripheral neuropathy. And then also, because that also gives us some idea of what we need to modify, or, to think more broadly about what our treatments are actually targeting, right? Especially if they're not going to address the peripheral neuropathy component. You also were talking about, was it a question really about what might be contributing to the ataxia, like a sensory dorsal column dysfunction versus something else like a cerebellar? Is that right? How we could tease it apart from other neurologic? Okay, great.
I think we're at time here, and we'll move on to the patient panel. But I did want to comment on how important this data is. So this information looks kind of maybe dry and abstract to the casual observer. This data is the kind of thing that will determine whether a drug can actually get FDA approval in our community. This is what they're showing here. I'll play it for them because it should be. It really is a major advance for the way we can now run trials in AMN. And I would draw an analogy here between maybe what the measures we were using before, which have technical names like EDSS and other things. They were just kind of coarser measures of how well people walk and function. And this one is sort of analogous to what Stefan was describing and moving from kind of the older long-chain fatty acid measures to the newer C26 LPC measure. It's a big difference where we can get a lot of new refined measures of how well someone is doing and whether they might be improving with or without a drug. So I just want to applaud the work that Amena and Eda have done here. It's a really big deal. Thank you guys for the work on this. This is a big step. Thank you.
Thank you.